Hi guys, if you're looking for solutions for what, how and कैसे करें for the forthcoming next exam, then this is the session in which I'll be able to provide you the guidance which is necessary. We'll be using the MCQs from the current plan, that is the Pro plan, so that we can test your reflexes and sharpen them further. So without much talking about all the miscellaneous aspects, let's get started for the current next pattern questions, and let's check out your responses. So very good evening. I missed out a couple of names there. Hi Ujjwal, Vikas, Medico, Akhil, Dr. Tanuja, Dr. Vamsi. So good to see all of you. Yes guys, I think so. The question database is important. The important topics remain the same, so I think it should be productive. Very good evening. Lovely Poison, Dr. Pika, Dr. Yadav. In case I missed a couple of names, do apologies for the same. So hi Karthik. So let's focus on the job at hand, guys. A lot of work to do in the next 1 hour, and my objective is to sharpen your reflexes, okay, and make you mentally adept at being able to handle anything and everything. I'm perfectly fine, phenomenal one. We have this 55-year-old, hi Abhimanyu. I think we can get Ram. Now let's not talk about it when कि next होगा 19 batch का या नहीं. So let's wait for the official notification. A 55-year-old woman होगा डॉक्टर साहब, आप आराम से, होगा या नहीं होगा, आप आराम से क्वेश्चन करो. Okay, so we have a 55-year-old lady. She's having nephrotic and she's presenting to the casualty today because of shortness of breath for the past 6 hours. Initially, a known case of nephrotic with breathlessness. I thought maybe pleural effusion could be developing or ascites could be developing in these patients due to hypoalbuminemia. And the pulse rate of the patient is on the faster side. Respiratory rate is 28 per minute. So, yep, there are derangement of vitals. The blood pressure is holding good at the moment. The physical examination of this patient is revealing presence of rales at the lung bases, and there's a cough, erythema and tenderness. Now, one of the key words in this particular MCQ is the presence of cough, tenderness and the erythema component present, which means that first you will have to think in terms of deep vein thrombosis in this patient, because every time we read about cough, tenderness and at the same time erythema, deep vein thrombosis should be the one that should be kept in mind. So I'm getting multiple inputs in this particular case, and what has happened in this lady probably is that pulmonary embolism has started. The clot dislodged from the deep vein, it's moving up, it's moving on to the lung circulation, which is resulting in respiratory distress in this patient. And since the patient is having pulmonary embolism, because nephrotic syndrome itself is a hypercoagulable state because of loss of protein C, protein S and antithrombin 3, so hypercoagulable state can be explained up. I think everybody has come up with the correct diagnosis, but when it comes to these integrated kind of questions where he's trying to mix it up with physiology, so I think that's the basic essence behind next, that he'll maybe give you a clinical domain and then he's gonna ask you about the physiological aspects for it. Option A says there would be a decreased alveolar arterial gradient. No guys, it would not be A, it would rather be an increased alveolar arterial gradient occurring in a patient. It would not be a decreased gradient. So why? I mean, if we look at the options here, first of all, I think we can easily rule out vasodilating neurohumoral substance in the pulmonary vascular bed. He's talking about nitric oxide per se. So in this particular condition, what is happening is that there is a perfusion defect which is occurring. The blood supply has become relatively less. So if there is hypoxia in the body, then the small a, I mean, if you are saying option number A for this question, you see small a is with respect to the partial pressure of oxygen in the alveoli. If blood supply to the lungs is reduced, then this small a will become relatively lesser. You see, P capital A O2 would mean the partial pressure of oxygen with respect to the alveoli. So air going inside the alveoli is normal. Air is going inside. It's not a problem of ventilation. It's a problem of perfusion. So the small a component would be relatively compromised. And the end result that's going to happen in this patient is that there would be an increased alveolar arterial gradient. So the answer to this question is not option number A. In case, in fact, in this particular question, he is mentioning regarding a decreased alveolar arterial gradient. It's an increased alveolar arterial gradient that is present. And then is the aspect of decreased physiological dead space. तो यार अगर lungs में there would be no blood supply, then the dead space would be relatively more. You see, dead space basically implies the amount of air that will not be or amount of air that will not be undergoing any exchange at the level of the alveoli. In this case, the problem is the perfusion of the lung is hampered. As a result of it, what is happening is that the dead space will also be increased. तो ये थोड़ा सा physiology based question है यार. इसमें ऑप्शन नंबर ए और बी दोनों रूल आउट हो जाते हैं. एल्वेलर आर्टिकुलर ग्रेडियंट और फिजियोलॉजिकल डेड स्पेस इंक्रीज हो जाएगा. प्लस मैंने बोला कि यहाँ पे कोई नाइट्रिक ऑक्साइड का वो बात कर तो रहा नहीं है, but any patient who's having pulmonary embolism will be exhibiting a hyperventilation. So the correct answer for the first question that we put up today is option number delta, that is alveolar hyperventilation. It's a physiological response that is occurring in this case, and I think that maybe the lag component or whatever was present in between, you just need to close your video and restart it again. Sometimes it could be a local internet issue at your end as well. I mean, not always at my end, so you just need to take care of that. So guys, the bottom line is every time you read about pulmonary embolism, what you have to remember is the treatment part of it, where you have massive pulmonary embolism, where we go in for thrombolysis. If it is submassive variety, we shall be using heparin in the patient. लेकिन इस सवाल को जो कि which was more of these physiology based questions, which are more of these physiology based questions, you need to understand the fact that the alveolar arterial gradient in these patients is going to be increased, क्योंकि small a जो है वो relatively less हो जाता है, and that's because the ventilation part is perfectly normal but the perfusion part is fine. Dr. Aditya, where would they be present? So I'll find it out for you. You can mail me for the same. Anyway, coming to the first question, I think the answer to this question, most guys have got it correct. It's more of a physiology based one, as I mentioned. The answer is delta. So let's move on to the second one for today, which I think again would help you evaluate your skills with respect to having learned the topic. We are having a 60-year-old diabetic and he is presenting with chest discomfort and breathing difficulty since early morning, and currently is on telmisartan, statins, metformin, standard medications that patients would be on. And because ECG is showing a T-wave inversion, so it basically means that the chap is suffering from myocardial ischemia. The clinical diagnosis that I'm putting for this guy is acute coronary syndrome. And I mean, diabetes is anyway a situation where increased cardiovascular mortality is present. And in this particular chap, since the ECG is showing a T-wave inversion, so that means that there would be evidence of myocardial ischemia. So either he's having non-ST elevation MI or he's having a unstable angina, and how to differentiate between the two will be using biomarkers. So the point is, I mean, obviously I'll be using biomarkers to differentiate between the two. There is no information with respect to biomarkers in this MCQ. Non-ST elevation MI biomarkers will show a gross elevation that would not happen in unstable angina. He's testing your auscultatory finding, which of the following would be found in this patient or is more probably found in this patient. So when we look at option number A, we are having a friction rub. Now he's not specified a pericardial friction rub or a pleural rub, but in a patient who's having a non-ST elevation MI, the least thing or the least possibility would be with respect to a pericardial friction rub in a patient. I mean, rather the myocardial infarction will be affecting the heart sounds in the patient. So I'm ruling out option number A. Reason why I'm ruling out option number A is because neither has he mentioned regarding pleural and pericardial, plus pericarditis is an unlikely diagnosis in this case. Yes, I think Ashish is getting that point correct. If we look at D, bilateral expiratory wheeze, so usually we'll be having is bilateral basal crepitations. To have a expiratory wheeze, you know that expiratory wheeze is something that's very classical for bronchial asthma. So there are two reasons why D cannot be the answer to this question. One is bilateral expiratory wheeze, because every time we read the word expiratory wheeze occurring, right, you have to think in terms of bronchial asthma or obstructive airway disorder. So there is no obstructive airway disorder as a presentation. Moreover, in any patient having a MI, basal creps would be present. So I'm left with two options: diminished breath sounds and fourth heart sound in this patient. So it's a good job that most of you were able to evaluate between B and C. You see, every time a person is having a MI, there is a risk of going into congestive heart failure. And if he goes into congestive heart failure, then pleural effusion can occur, and that can affect breath sounds also. But first of all, what happens in myocardial infarction, or what happens in unstable angina would be that the patient would be having a stiff, stunned ventricle, Why I'm saying it's stunned is because there's a sudden occlusion of the coronary artery, and because of this there's a stiffness in the myocardium as well. So we are having a stiff stunned myocardium, because of which the atria को ज़्यादा जोर लगाना पड़ेगा. Because we are having a stiff and a stunned myocardium in this patient, the atria of the patient will have to apply more force, and because of the fact that there would be more force required for the atria to contract, therefore fourth heart sound would be present in these patients. डॉक्टर साहब इंस्टाग्राम पे ना अगर आप मेरी उसमें लिस्ट में नहीं हो तो देन द मैसेज वुड गो इनटू स्पैम एंड देन इट वुड बी डिफिकल्ट टू रिट्रीव. सो माय ईमेल आईडी पे भेज दो marwamedicine@gmail.com and I'll try to respond to it. So yes, Sayak Chakrabarti, you perfectly right. There would be a stiff ventricle in this particular case. It's stunned. There's a myocardial ischemia which is occurring. And what we need to do in this particular case is simply the fact that the logic behind answering this question is that the atria will contract with more force against a physical resistance. That's a stiff ventricle, which is why the fourth heart sound would be present in these patients. So the correct answer for this question is option number C. And you can just close and okay. आशीष कौन से वाला आपने पहले क्वेश्चन एक्सप्लेन किया हुआ. ओके, मे बी दिस वन आई माइट हैव डन इट एट सम पॉइंट ऑफ टाइम. सो ग्रेट. एनीवे, in case you could answer this correctly. So we are sorted with the second question for today, and let's look at the third one. I'll try to put some easier ones today so that we can just get the rhythm going. So let's look at your reflexes for the subsequent one. Dr. Sayak Chakrabarti has given a very good comment with respect to the atria contracting vigorously against a stiff ventricle, so that would be perfectly fine. So the QBank is in the process of updation, doctor, and there would be multiple new questions that would be coming in. Absolutely right. Okay, moving to the next one, we are having this 24-year-old lady. She's having a fluttering sensation in the chest with dizzy spells, and she's had this episode like this for the third time. So that's a cause of concern. She's an asthmatic. Heart rate is just racing, 150 per minute. Blood pressure is doing good, but considering the fact that in this particular patient, I'll just zoom in into the ECG of the patient, and you can notice that there is one hidden P waves. In fact, the P waves cannot be deciphered because this is a supraventricular tachycardia. It's a narrow QRS complex tachycardia. You can see the R and the S waves is literally jumping on each other. So considering the fact that we are having a narrow QRS complex, and at the same time we are also having a tachycardia, the heart rate of this patient is mentioned also, plus is racing more than 150. So considering the fact that there is hidden P waves, there is a narrow QRS complex, the diagnosis of this patient is paroxysmal supraventricular tachycardia. So let's look at answers here. I am getting a B, I'm getting a C in this case, I'm getting a D also in this case. So we'll just rule it out. The answer will not be D because the patient is having blood pressure of 100 by 70. Anything less than 90, we are gonna go ahead with the cardioversion, but we'll not go for cardioversion in this particular case, primarily because the blood pressure is doing fine. A lot of guys have mentioned C, that is oculocardiac massage for this patient. See, oculocardiac massage will not help in definitive treatment for this patient. Is asking you what is the best step for this management of this patient. Is not asking what is the initial management that you will be doing. No guys, the answer is not C for this patient. Oculocardiac massage, anyway, we go for vagal maneuvers in the form of a face ice pack, or we go in for a vagal maneuver with respect to Valsalva maneuver, or a vagal maneuver like a carotid sinus massage. But oculocardiac massage is not done because you can be damaging the eyeball of the patient. So again, not a very good option. We're left with B, that is adenosine, and I think you guys are doing the same mistake, which I think majority of people have answered B for this question, and I think you guys are wrong. Why? Because you're doing the same mistake which happened in NEET PG 2023 also, that he just put up a very simple fact that the patient at the moment is a asthmatic. I would not like to use adenosine in an asthmatic, because adenosine anyway can trigger bronchospasm, though it's a transient bronchospasm. But you can understand, if somebody is already having a tachycardia, heart rate is racing 150, and you cause narrowing of the airways, the guy will freak out because he will literally choke. The answer to this question is not option number B, guys. Just don't fall in the trap. And the same thing happened in the NEET PG 2023 also, that a lot of guys, they casually read. I mean, the question in NEET PG 2023 was for atrial fibrillation. But what he had done very smartly was that in that MCQ of atrial fibrillation, he had very silently mentioned that the patient is an asthmatic, and considering that patient is an asthmatic, we would not be comfortable using beta blockers in the, I'm talking about NEET PG 2023 MCQ now. The atrial fibrillation in an asthmatic, we are not going to use a beta blocker. We'll be using calcium channel blocker, that is verapamil, and the same thing would be valid for this case also. So the correct answer for the current question on the slide is option number A, that is verapamil. I'll just make you quickly summarize this point once again. In fact, that's what we tend to usually overlook. This happened in NEET PG 2023. That is why I have put up this MCQ before you. So let's do this question quickly once again. I think everybody could pick it up that it is a paroxysmal supraventricular tachycardia based on the clinical profile, narrow QRS, plus there's a tachy present in this patient. The heart rate of this patient is given, plus can be seen on ECG also, about 1.5 large squares separating the two. So the heart rate is pretty dramatically on the higher side. Now, considering the fact that there is a narrow QRS tachy, hidden P wave, PSVT satisfied, D option is ruled out. Why? Because the BP is stable. C, you might injure the eyeball of the patient. Between B and A, what you have to pick up was asthma. If asthma and COPD was not given in the question, then the answer would have been option number B, adenosine. We go in for chemical cardioversion in all patients. And anyway, with respect to verapamil, I have already mentioned. No, doc, the answer to this MCQ would not be amiodarone. Amiodarone is used in atrial fibrillation, or it is used for management of patients of ventricular tachycardia or a ventricular fibrillation. So it doesn't matter. I mean, sometimes I will give you some easier ones, and then I'll give you ones where I'll try to replicate whatever the examiner is trying to do, that is stump us. And this you can treat as a googly, the ball that spins the other way around. You think that it will be off spin, turns out to be leg spin. So that was the kind of question that came in the exam, and that is why we have talked about it. So moving to the next question, we are having yep, Sayak, you right with respect to VT, but at the moment structurally abnormal heart. Yep, but the question was on PSVT, the one we are talking at the moment. Okay. Ankush, we do not do defibrillation in defibrillation कहाँ करते हैं यार, PSVT में नहीं करते ना defibrillation. Since Ankush mentioned that point, तो मैं यहाँ लिख देता हूँ that cardioversion and defibrillation are not the same. What is the difference? Please go to rapid revision or go to the main videos and you will be able to evaluate it. Defibrillation is done only for two things, that is pulseless ventricular tachycardia and ventricular fibrillation in hemodynamically unstable patients. And as I've explained, cardioversion, defibrillation not the same. The reason why we're not doing cardioversion is because BP is stable at the moment. Moving to the next one. This is about a kid. He's about 10 years of age and he's unconscious for the previous 2 days. He has been ill for the past 4 weeks, and he's been shown to multiple doctors, as our patients will continue to do doctor shopping. Now on examination, the chap is febrile with signs of meningeal irritation. So in an Indian exam, every time you are having a child who is ill for a long duration, long haul, I mean 4 weeks, meningeal irritation, what is coming to your mind is obviously a tubercular etiology. And let's look at the CSF findings in this patient. So the opening pressure is little on the higher side, cell count is more. I mean, normally we have 0 to 4 lymphocytes. Here the cell count is dramatically increased. Then most of them are lymphocytes. And okay, Dr. Ansari, in case you found it, that's great. It's mainly lymphocytosis in CSF in an Indian exam is obviously tubercular meningitis, plus the proteins are elevated. Normal protein is 15 to 45 milligram. And in this case, what's happening is that the protein values are elevated. So considering the fact that the patient is having tubercular meningitis, let's look at the answers that you guys would be giving me. You have to answer as 1, 2, 3, 4. I got 4 as an answer. Well, it cannot be 4. All options cannot be correct because in tubercular meningitis, guys, you will not be using acyclovir. So I'm ruling out option number Bombay in this particular case, because when it comes to option number B, the main problem is that acyclovir is one that you would be using for cases who are having viral encephalitis and not for a case of tubercular meningitis. So option number B can be ruled out. Okay, I'm getting A, C, D as an answer in this case. CSF culture is required before starting treatment. No, guys, I've told in tubercular meningitis or in any bacterial meningitis, you have to first start empirical treatment. But suppose you are saying, you know, the test that you will ideally be doing in this case would be a PCR CSF for Mycobacterium tuberculosis. And in case you plan to do a PCR CSF for Mycobacterium tuberculosis, the problem is that this PCR facility may not be working available in a tier 2 town. भाई आप वेट थोड़ा ना करोगे कि भाई पीसीआर का रिपोर्ट आएगा तो मैं डायग्नोसिस करूंगा, तो 4 कैनॉट बी द आंसर एंड इवन आई मीन ए से डी कैनॉट बी द आंसर टू दिस क्वेश्चन. व्हाई? बिकॉज ऑफ द फैक्ट दैट empirical treatment is to be started for both acute and tubercular meningitis, primarily because of the fact that if you delay, the damage that is gonna occur will be fairly severe. इट्स ऑलवेज एम्पेरिकल ट्रीटमेंट दैट इज स्टार्टेड. तो ए से डी भी नहीं होगा. और डी तो आप पढ़िए ना, ध्यान से पढ़िए सर. स्टेरॉइड्स डू नॉट वर्सन, steroids rather improve cerebral edema. We are all aware of the fact that steroids जो होते हैं, they are one of the main agents that you will be using for management of a patient who's having a vasogenic cerebral edema. So because of the fact that I mean steroids are gonna cause a dramatic improvement in these patients. Yup. Uh, Okay, so we'll be going in, sir. We can do a lumbar puncture in the patient, but we can start empirical treatment. So the correct answer for this question is option number A, because every time you will start ATT in a patient, there can be a possibility of hepatotoxicity by pyrazinamide. So the correct answer for this multiple choice question is option number 1. That is, liver enzymes in the patient should be checked regularly. I'll rule out the remaining options once again before you. You do not need to do a CSF culture in a patient before starting treatment. Empirical treatment is to be started because you may not be having facilities for a workup in a patient immediately, and the report will not occur, will not come immediately. Even if it was acute bacterial meningitis, no, it will take at least 48 hours for the culture to show growth of some organism. So the microchap will revert to you after 2 days. For tubercular meningitis, the culture is going to take weeks. So we're not going to wait for that report to come and then initiate treatment. We'll start empirical treatment in a patient. And more importantly, the steroid component is always going to be useful because that reduces the vasogenic cerebral edema in a patient. So the D statement is also wrong in this case. The wrong statement is, it is written steroids worsen cerebral edema. Steroids would be causing an improvement. Considering that option number A is the only one that fits the bill, that is why point number 1 is correct. And because in the current pattern, more than one option can be correct, which is why I thought I should put up a question like this. So, yep, I mean, even in INI-CET, somebody mentioned a comment regarding it. So, I mean, these questions, because cases are common, no, these tubercular meningitis, viral bacterial meningitis cases keep on getting admitted in the casualty on a sporadic basis, which is why questions on the same are asked. So we are sorted for the previous one. The answer to this one on the agenda where the diagnosis for tubercular meningitis is option number 1. And now we are going to talk about, I'll not say the disease. Let me just see how you guys pick it up. We have this 70-year-old lady who's having a difficulty in walking and maintaining her balance. And hubby says that, husband says that she walks as if the feet are glued to the ground. So the language, the question is basically trying to tell you that the patient is having a magnetic gait. And the moment magnetic gait comes in the picture, you know that the part of the brain that can be involved in this case is the frontal lobe of the patient. So some kind of frontal lobe pathology can be present. She's also become forgetful. That's a cause of concern. She's on losartan for hypertension. 70-year-old lady, I mean, hypertension could be present. Oxybutynin for urinary incontinence. So, yep, the consideration is that because she's having urinary incontinence also, she's become forgetful as well. So, if you add up all the issues, that is gait ataxia and incontinence and forgetfulness, you work out to a diagnosis of normal pressure hydrocephalus. You read about normal pressure hydrocephalus either as AID, that is ataxia, incontinence and dementia, or you go with the conventional way, that is wet, wobbly and wacky. I mean, that's the American perspective behind it, wet, wobbly, wacky. Or I think AID would be a much more easier way to remember it. The way they ask it in our exams is mainly gonna be with respect to ataxia, then is incontinence, then is a dementia occurring in this patient. So the diagnosis of the patient is normal pressure hydrocephalus. You can also notice in the CT head of this patient grossly dilated lateral horns of the ventricles. Considering that both the temporal horns, lateral horns are grossly dilated, so that gives credibility to the diagnosis as NPH. And the question is mainly saying what is the next step for management of this patient to improve her gait. So what is trying to talk about is what is called as a Fisher test. And what I imply by Fisher test is that we'll be removing some CSF, and the moment we remove the CSF from this patient, we anticipate improvement in the gait of the patient. That process of therapeutic CSF removal, you know, we are removing 30 ml. The query, lot of time people say, sir, you're removing 30 ml. I mean, is that safe? then the point is, doctor, that patient could have undergone a shunting subsequently, so those shunt placements. But the point is, the therapeutic management for this patient is a removal of CSF. Is 30 ml a large amount? Yep, but that would be produced in the next 1 hour, because the rate of CSF production would be something a little in excess of this, but 20 to 25 ml per hour. So it's a safe limit that we are removing the CSF, and that will cause a dramatic improvement in the management of this patient, and subsequently VP shunting would be done in these patients. But the initial management in these patients to cause an improvement in gait is a removal of about a few ml of CSF, which helps in both diagnosis as well as in the management of this patient. Yeah, the total amount of CSF is 150 ml, doc. That's perfectly fine. The correct answer for this particular question is option number A, Hakeem's triad. Yes, Dr. Sayak. Yep, that's the point I have said in my recent, I think, shorts or so. Hakeem's triad is the dementia, ataxia, and the incontinence component. Very good. So I think we are sorted with the very first one. Let's with the current question on the agenda, the option number A has been satisfied. And somebody mentioned extradural hemorrhage. No, doc, there is no history with respect to extradural hemorrhage that will be going in for this. Yes, Dr. Somapal will be going in for shunting subsequently. Yep, shunting has to be done in these patients subsequently. So moving on to the subsequent management of this patient, a 30-year-old athlete has presented with recurrent episodes of right upper quadrant pain. The liver span is normal, the icterus component is absent at the moment. So right upper quadrant pain, I'm assuming the liver of the patient is the one which he's talking about, though there are multiple reasons for the liver involvement. Though the good news is there's no jaundice. There is unfortunately a mass in the right lobe of the patient, and the biopsy of this patient is showing larger than normal hepatocytes, which are containing, like, he's basically mixed it up with pathology. He's talking about large, cells which are larger than the normal looking hepatocytes. There are regular septations present, but the portal tracts and the bile ducts are absent. And he's expecting you to make a diagnosis, one, on the basis of the findings of pathology that are given, and second, he's expecting the answer for this particular question. So I had a couple of inputs there. The bottom line is, if you look at A, that is PVC exposure, that is polyvinyl chloride exposure, this is mainly going to be responsible for a tumor of the liver, that is angiosarcoma. So can this be angiosarcoma? Well, angiosarcoma will have some blood vessel component present, and the histopathological report of this patient does not mention any angio component present. So I'm ruling that as a possibility. And I'm ruling out option number D also, because carbon tetrachloride causes fulminant hepatic failure. So there is no necrotic hepatocytes which are given. There's no death of hepatocytes which are described. So A can be ruled out because there's no blood vessel component given. D can be ruled out because there is no evidence of no mention regarding fulminant hepatic failure, because fulminant hepatic failure is supposed to have presence of jaundice. We're left between B versus C, that is aflatoxin and steroids. Then aflatoxin is the risk factor for development of hepatocellular cancer in a patient. Between B and C, we will have to look at, okay, so I'm getting B also and I'm getting a C also. Then hepatocellular carcinoma, it would be having presence of portal tracts and bile ducts. What is happening in this case, he's not having a the histopathological features which are present in this patient is with respect to a tumor which is by the name of hepatic adenoma. And hepatic adenoma, as you know, is a tumor which can be seen with respect to usage of steroids. In female patients, hepatic adenoma will be seen with respect to OCP, and in a male patient, considering that he's an athlete, he might be using anabolic steroids. The correct answer for this particular question is option number C. The logic to be used is that the histopathological image in this case points in favor of a hepatic adenoma. That is one. And second, that one of the risk factors for hepatic adenoma is either oral contraceptive pills or it's gonna be anabolic steroids. So option number C, which was, I think most of the guys were able to narrow it down, is gonna be the correct answer. I'll rule out the options once again. He's an athlete. Yeah, that's another reason. Because he's an athlete, he might be using anabolic steroids, which is fairly common because they would be using it in performance enhancement. So athlete, the athlete word is never diagnostic. That would always signify good cardiovascular health. It would never be diagnostic. But yep, possibly, as Ankush raised, possibly that since he's an athlete, he might have tried to enhance his performance and might have used anabolic steroids in this case. So we'll first look for a common tumor, that is hepatic adenoma. Then we'll think in terms of hepatocellular carcinoma also. So between B and C, yes, two close choices. The correct answer for this question is option number C. So good job, guys. I think you are doing a great job. Majority of the questions, logically, you are being able to work it out, except for a few of them. Why is icterus absent in this case? See, hepatic adenoma will be a limited mass. The remaining part of the liver will compensate. There's no hepatocyte necrosis. No, for jaundice to occur, you need to have a critical loss. Rather, you are having a tumor where the hepatocyte number is increased. You see, for a jaundice to occur, you need destruction of hepatocytes. You need to have a decreased capability of conjugation to occur. Or there has to be some physical obstruction present in the biliary pathway, which can result in development of jaundice. So since we are not having any destruction, we are not having any physical obstruction, there is no inflammation. So there would be no icterus present in this case. Moving to the next question, we have this lady who's complaining of tremors in both the hands that worsen or holding a cup of tea in either hands. Like, she's saying that my hands shake. Like whenever she's holding a cup of tea, her hand is shaking. So she's trying to hold it with the other hand and still she's having a tremor. And even when she's typing in her mobile, on a mobile browser, the tremor part is present in her fingers. And considering the fact that the tremors are disappearing on keeping hands in the lap, when patient is not, it's a kinetic, it's a tumor which is coming on doing a task, it is disappearing when the patient is keeping his hands in the lap. And more importantly, in these patients, she can get out of the chair and use washroom unassisted. So there's no physical disability present. There's no significant physical disability present. So first we have to work out the diagnosis of this patient, that is she, because she's taking beta-2 agonist, are these tremors being caused by beta-2 agonist, or are these gonna be signifying some medical disorder? Well, the first and the foremost thing is that if it's gonna be beta-2 agonist causing a tremor, then the tremor will be of short duration. The tremor will disappear in a couple of minutes. Like lots of time, people when they do nebulization, you will notice people when they do nebulization, they'll tell you, sir, I'm getting tremors, or I feel as if ants are crawling below my skin, or like the tremors in the fingers can be noticed, but then it would be of a short duration. So it is unlikely that in this patient that the tremor of nebulization with beta-2 agonist is causing inability in holding a cup of tea and even typing on a mobile for a long duration, that the patient is complaining, because it should be shorter duration. See, when it comes to formoterol in a patient, the basic point why I am ruling out option number A is that it will be causing tremors for relative a short duration. It would not be tremors that would be causing a significant amount of disability to the level that activities like drinking tea or coffee or water would be hampered. So I'm ruling out option number A in this case. The clinical diagnosis of this case is essential tremors. The clinical diagnosis of this patient is essential tremors. Essential tremors are one of the commonest tremors that would be seen, where whenever the person is doing some task, and that would be a young person, this is a young person, whenever the young person is doing a task, that is when the tremors are coming. And when he's keeping his hand in his lap, then the essential tremors are relatively disappearing. So the drug of choice for treatment of essential tremors is propranolol. But then again, the same question is that propranolol, if we are using in an asthmatic, that will worsen asthma. The correct answer for this is not D. So sodium valproate is a drug that is used for management of epilepsy. The drug of choice for treatment of essential tremor is propranolol. And because he is having a history suggestive of asthma as well, so I'll not give propranolol for this patient. The correct answer for this question is option number beta. So you can notice that he's mixing up pharmacology, and a lot of these MCQs where he's going to mix up pharmacology, वो वहाँ पे asthma डाल देगा. जैसे I'll just go back, one of the questions that we discussed today, जहाँ पे asthma came in the discussion and changed the entire perspective. This happened in NEET PG 2023. So I deliberately put up a question like this. मैंने बस question change कर दिया. Instead of atrial fibrillation, I made it PSVT, and asthma part was neglected. Similarly, in this particular case, the bottom line is that we would not give propranolol to an asthmatic, considering that the asthma attacks can worsen in these patients. So therefore, the correct answer for this would be primidone. I mean, the objective is obviously to reduce the disability in a patient where he can do these routine tasks. So no, it's not primodrine, doctor. It's not primodrine. It's primidone that is given, right? So please read the pharmacology component. Absolutely. It's a barbiturate that will calm the patient down. I mean, after all, for essential tremors, we need to either use propranolol or we can be using barbiturates in the patient. Corrector of tremor would be fine tremors, doctor. Formoterol always results in development of fine tremors, and these fine tremors will disappear in the next couple of minutes. So patients who are having, I mean, if you talk to anybody who's an asthmatic and suppose is having an attack, then he will have to use a higher dose of beta-2 agonist. That's when the tremor will come in. So routine taking a MDI, the amount of drug delivered will not be so high that the tremor component will kick in. Can happen in some patients, but mostly after nebulization, you will notice all asthmatic patients who come to your hospital, if they're having after nebulization, if they are going to be, having those tremors, fine tremors, they'll disappear after a while. Here, because the symptoms are much more persistent, which is why we'll be using primidone for management of these patients. The correct answer for this one is beta. So it's the objective of today's discussion is just to sensitize you to, that he can mix up the pharmacological perspective with general medicine, or he can mix up therapeutics basically. He can ask therapeutics in more detail. Yes. Dr. Paul, that is the feature for diagnosis of essential tremors, that if he is not doing any activity ना, अगर वो आराम से बैठा है तब नहीं होगा tremor, पर जब वो काम करने की कोशिश कर रहा है, that is when tremor. So in a young person, if you are having a clinical presentation like this, then it is essential tremors. इसका एक और स्पेशलिटी होता है ना, अल्कोहल पीने के बाद में ट्रेमर जो होता है गायब हो जाता है. तो कहता है मैं पीता हूँ, ड्रिंक करता हूँ, बियर पीने के बाद में ट्रेमर गायब. So that's again another hint that could be given in questions, like in lot of USMLE type of questions. No, they'll mention a patient comes to you and he says that he has this tremor whenever he's trying to do routine activities like trying to drink water, but he says after drinking beer, then I can drink anything. I don't have a tremor present. And why not sodium valproate? Sir, sodium valproate is an anti-epileptic drug. Sodium valproate may be used for management of chorea, but we do not use sodium valproate. I mean, for epilepsy is fine. We're not discussing epilepsy at the moment. And yep, exactly. Let's move on to the next one. We are having this 50-year-old man with behavioral issues. Is irritable and has difficulty doing tasks due to involuntary movements in hands. So one more question on the same involuntary movements in a 50-year-old chap. This time I've increased the age group. Last time it was a 25-year-old chap. Now we are having a 50-year-old chap. This time no asthma present. And on workup of this patient, slit lamp examination is normal. So the examiner is himself trying to rule out possibility of KF ring and a Wilson disease. He has also mentioned normal ceruloplasmin levels. He has also mentioned regarding slit lamp examination. Both of these points towards the fact that he is himself trying to rule out Wilson disease for you. He has also mentioned that the MMSE score of the patient is 21/30. So there is a evidence of dementia. Please comment in the chat box. When do you say dementia? MMSE score less than how much is dementia, guys? Yep. The dementia component would be a score less than 24 is what when we say presence of dementia. He has ruled out Wilson. He has also ruled out vitamin B12 deficiency that can cause reversible dementia. If we are ruling out two important causes, one is subacute combined demyelination of spinal cord with vitamin B. I mean, there is anyway no features which are given with respect to B12 deficiency in this question. It is just that you have to link up the fact that there is tremors, there is involuntary movement. He's not mentioned the word tremor, he's mentioned involuntary movements. And at the same time, he has also mentioned regarding forgetfulness developing in this patient and behavioral changes occurring in a patient. So the diagnosis of this patient would be kept as Huntington's disease. If you're saying frontotemporal dementia, then frontotemporal dementia can be a possibility. Yep, can be a possibility in this case. True. That is, Umar made a valid point there. I mean, frontotemporal dementia is one of the manifestations. Can be behavioral issues, but then involuntary movements in the hand is not explained. Why frontotemporal dementia is being ruled out in this question is because though you had a valid point from the first line of the MCQ, behavioral issues would be present in frontotemporal dementia also. But do we get involuntary movements in the hands in a patient of frontotemporal dementia? No. But in Huntington's disease, we are having Huntington's chorea. That can explain the involuntary movement. People saying parietal and temporal lobes. Guys, parietal and temporal lobe is a feature of Alzheimer disease. देखो वो यहाँ पे क्या देख रहा है, जो C और D है वो तो अल्जाइमर्स डिजीज का फीचर होता है. अल्जाइमर डिजीज 50 ईयर पे प्रेजेंट नहीं करता है. डिफ्यूज कॉर्टिकल इन्वॉल्वमेंट एंड parietal and temporal lobe involvement is a feature of Alzheimer disease. Alzheimer disease will not present at 50 years of age. तो C और D तो वैसे ही बाहर हो जाता है एज ग्रुप पढ़ के. अब बचा A and B, and between A and B the logic is one close answer was B, frontotemporal dementia. Why did I rule it out? I said involuntary movements in the hand are explained, so caudate nucleus is the one that is affected. So because we are talking about basal ganglia involvement, that is why caudate nucleus involvement in the patient, which is why the answer for this question is option number A. I think we are sorted for this one. I'll just read the question once again. Next 30 seconds, a quick look. We are having a 50-year-old chap with behavioral issues. See, if this question was for a younger age group with behavioral issues, personality changes, and more importantly, if there is deranged liver enzymes in a patient, Wilson disease is to be considered. Age group for Wilson disease presentation would be 10 to 20 years of age. I mean, it could be late first decade, or it could be late second decade in a patient. That's the usual presentation, and derangement of liver enzyme at some point of time or positive family history in the patient would be given. For Wilson tetra, okay, for this one, yeah, tetrabenazine is used for Huntington disease. That's okay. If this was a younger patient with behavioral issues, involuntary movements occurring in the hand, rigidity occurring, and there is deranged liver enzymes, Wilson is to be considered. At 50 years of age, every time he mentions about involuntary movements in the hand with behavioral issues and dementia coming in, you have to think in terms of Huntington's chorea in a patient. This disease would be having excess of dopamine. And because there is excess of dopamine, that is why a dopamine depleter has to be used in this case. And that is why I think Dr. Study Corner mentioned perfectly right. Tetrabenazine would be one of the drugs that would be used. So fairly evaluative question is trying to mix up issues of psychiatry with general medicine, and is putting up a question. When you're reading this question, I agree it's slightly a longish one, because he's tried to prolong our misery by mentioning regarding normal B12 levels and normal ceruloplasmin levels. But it's important to rule out B12 deficiency, which is a cause of reversible dementia. It's important to rule out Wilson disease in this patient. So that's the differential thought process that you need to have. And yep, anyway, I mean, most guys did very well by picking up that this would be Huntington's disease. I've given explanation for why answer is not B. Frontotemporal dementia will not present with involuntary movements, though the initial first line of the MCQ would be fine. Ashish, yep, because there is a caudate atrophy, that is why the ventricles will look relatively bigger, and that's why the radiologists will use the term boxcar ventricle. Good job. Let's move on to the next one. He says, which of the following would be useful in management of relapses in a patient of multiple sclerosis? Preventing relapses in multiple sclerosis. For prevention purposes, the drugs used would be different from the ones that are used in active intervention. So he's asking regarding what would you use if there is a relapse. Okay, I've had a single answer, so I'll just wait for a few more seconds while you guys are gonna give me answers. Yep, guys. Exactly, multiple sclerosis, every time there is a relapse occurring. See, all these drugs, natalizumab, glatiramer, beta interferon, they are gonna be useful for prevention. They are gonna be preventing, they are disease modifying drugs. They will prevent relapse from occurring. Since the question is asking regarding what are you gonna do for a management of a patient of multiple sclerosis, immunological disorder, we'll have to give steroids in this particular case. The question did not mention, guys, prevention. The question said, what will you do for the management of this patient? He did not say which is most efficacious in preventing development of new lesions. Then it is okay. For new lesions prevention, it is natalizumab. Multiple sclerosis का highlight होता है, we use McDonald's criteria for diagnosis of multiple sclerosis. The question will always talk about a female patient who would be having a unilateral onset blindness. That would be unilateral optic neuritis developing in a patient. Every time a question begins by saying female with bilateral optic neuritis, you need to consider a differential, that is neuromyelitis optica. Neuromyelitis optica की भी मैं बात करूंगा, but every time you read a question regarding a female patient, unilateral optic neuritis developing, sudden onset blindness developing in a patient, I mean very weird, no? Patient says कि आंख से दिखाई कम देता है, उसका visual acuity धीरे धीरे कम हो रहा है, तो she went to optometrist thinking that उसको she needs glasses. But what is happening in this case is that though she will change her glasses, she will not be able to see properly because there are plaques developing in her optic nerve unknown to her, and because of this the visual acuity will become decreased. उसका कलर का जो सेंस है वो कम हो जाएगा. वो बोलेगी मैंने जो कलरफुल ड्रेस डाला हुआ, लाइक दिस गर्ल शी इज वेयरिंग अ कलरफुल ड्रेस, शी सेज आई कांट पिक अप द कलर्स. सो कलर विजन कम होना शुरू हो जाता है. सो इनिशियली इन ऑप्टिक न्यूराइटिस द क्वेश्चन विल डिस्क्राइब अ यंग फीमेल, शी इज नॉट एबल टू सी द कलर्स ऑफ हर ड्रेस, शी इज नॉट able to see properly, she went to optometrist thinking it's a refraction disorder, and later on we found out that she's turning blind because of damage to her optic nerve. And the highlight of these patients is, yes, Dr. Kamar, I'll be taking it on my channel also, but then you can attend this one also, this would be beneficial for you. Subsequently in the same patient another history would come कि जो symptoms हैं वो heat exposure पे बढ़ जाते हैं. Like I mean the patient is saying that every time I take a sauna bath or I take a steam bath, या जब भी fever होता है, then on heat exposure symptoms increase हो जाते हैं, which is called as Utov phenomenon. So we don't read about this kind of language anywhere else in medical literature. I mean every time you read a question where there's visual complaints, symptoms increasing or heat exposure. Symptoms कैसे होंगे? Cramps, that is spasticity in her hamstring. पेशेंट शी वर्क्स आउट इन अ जिम एंड शी कहती है कि मैंने पिछले कुछ दिनों से महीने से वर्कआउट नहीं किया ठीक से, बिकॉज एवरी टाइम आई गो देयर मुझे बहुत जल्दी क्रैम्प्स हो जाते हैं. शी इज थिंकिंग कि मे बी आई एम डूइंग टू मच ऑफ हार्ड एक्सरसाइज सो आई एम गेटिंग क्रैम्प्स. दैट क्रैम्प्स आर कमिंग बिकॉज ऑफ द स्पास्टिसिटी ऑफ द हैमस्ट्रिंग्स दैट शी इज occurring, and she is not realizing the significance of it. You as a doctor will be able to pick up those focal signs present in these patients, and then you'll do a workup which will show presence of plaques, and these patients can be given drugs to prevent the development of further plaques in the brain. That is called as Dawson fingers. In fact radiology से link करेगा तो he'll talk about Dawson fingers are a radiological finding of जो मैं plaques बोल रहा था medicine domain से, that would be technically in radiology perspective called as Dawson fingers. And for these patients, for prevention of newer lesions to develop, yes, you will be using BCD, but for relapse you will be using steroids in the patient. The correct answer for this one would be option number A. Sir, they are given, I think you have not been able to go through the entire, I mean lots of time, no, their questions would be given in those tests, and that is when you'll be able to evaluate them. Okay ji. Let's move on to the next one. This is a 65. Sir, वो जरूरी नहीं ना कि वो एक ही जगह पे present होते हैं ना system wise में. Sometimes they are given in the newer tests which are given. So you need to go through the QBank once. As I said last time, परिक्रमा करना है sir. Do the entire QBank once very thoroughly. Okay. Methylpred, Dr. Huda, Dr. Methylpred would be used, not Dexa. 65-year-old hypertensive patient has presented with the complaints of palpitations and weakness in the arm since morning that is improved by itself. So that means the person is having a transient ischemic attack. I mean the diagnosis of this patient, hypertensive patient, and then there is palpitations and weakness in the arm. I'm focusing on weakness in the arm since morning that is improved by itself. So I'm thinking it's a transient ischemic attack. The bad news is the transesophageal echo is showing presence of clot in the left atria. ECG of the patient is showing a irregular RR interval. You can notice the RR interval of the patient is changing. There is absence of P waves. So the clinical diagnosis of this patient from the ECG perspective is atrial fibrillation. Atrial fibrillation is causing left atrial appendage clot, and the fragments of this clot are going up in the brain. Luckily, the clot was disintegrated by the anti-clotting system in the body. We have protein C, we have protein S, we have antithrombin 3. तो anti-clotting system ने clot को dissolve कर दिया, but there is a possibility that again a fragment will go up and the patient may not be so lucky. यहाँ पे it's a two-step question. First you have to pick up there is atrial fibrillation. एंड एट्रल फिब्रिलेशन वाले पेशेंट में क्लॉट प्रेजेंट है, वो क्लॉट लकीली ऊपर गया एंड इट गॉट डिसइंटीग्रेटेड ड्यू टू एक्शन ऑफ द एंटी क्लॉटिंग सिस्टम इन द बॉडी. नेक्स्ट टाइम पेशेंट में नॉट बी सो लकी एंड ही विल गो इनटू फुल ब्लोन स्ट्रोक. तो बोल रहा है कि करेंगे क्या. तो यहाँ पे आंसर्स आ रहे हैं कि जैसे हम रेट कंट्रोल करेंगे विद एस्मोलॉल फॉलोड बाय केमिकल कार्डियोवर्जन. तो पहले मुझे ये बताओ कि क्या रेट कंट्रोल से या केमिकल कार्डियोवर्जन से. पहली बात तो क्या सीधा रेट कंट्रोल के बाद केमिकल कार्डियोवर्जन करते हैं, बीच में एक स्टेप होता है ना एंटीकोएगुलेशन. I mean why a lot of people are saying C, तो मैं इसलिए उसको क्रिटिसाइज कर रहा हूँ. Why C? Because it is rate controlled followed by anticoagulation then is chemical cardioversion. Guys, there is a clot in the left atria of the patient. वो कभी भी ब्रेन में गया तो पेशेंट को स्ट्रोक डेवलप हो जाएगा. तो सबसे अप्रोप्रिएट स्टेप क्या होगा, सबसे पहले तो उसका एंटीकोagulation करना पड़ेगा ना. We'll have to do anticoagulation in this patient. He's saying what is the most appropriate management for this particular patient. तो C गलत क्यों है कि रेट कंट्रोल तो ठीक है आपका पॉइंट. आई एम नॉट सेइंग कि रेट कंट्रोल आपने गलत बोला, लेकिन उसके बाद देखो ना क्या लिखा है, फॉलोड बाय केमिकल कार्डियोवर्जन. तो बीच वाला स्टेप तो हम खा ही गए. हमने तो एंटीकोएगुलेशन करा ही नहीं, जबकि इसको सबसे ज़्यादा ज़रूरत किस चीज़ की है, इसको सबसे ज़्यादा ज़रूरत तो एंटीकोएगुलेशन की है। तो सी तो इसलिए बाहर हो गया क्योंकि सीक्वेंस मेंटेन नहीं हुआ। अब डी देखते हैं। डी से केमिकल कार्डियोवर्जन फॉलोड बाय एंटीकोएगुलेशन, तो अगेन चेंज हो गया, इट इज एंटीकोएगुलेशन फॉलोड बाय केमिकल कार्डियोवर्जन, सो द स्टेप्स आर नॉट बीइंग फॉलोड, सो इस वजह से सी और डी तो बाहर हो जाते हैं। बी में बोलता है इलेक्ट्रिकल कार्डियोवर्जन, अगर मैं इलेक्ट्रिकल कार्डियोवर्जन कर दूंगा, ग्रेट एट्रियल फिब्रिलेशन विल स्टॉप, बट द प्रॉब्लम इज द मूवमेंट द फिब्रिलेशन विल स्टॉप, द क्लॉट्स व्हिच वर स्टक because of the twitching will now go out in the brain and cause development of stroke. See, you don't need to be straight away treating the disease, you first need to treat a problem that is occurring at the moment, which is a clot which is present here, and therefore anticoagulation is one of the most important steps for management of this patient, और उसके बाद में हम बाकी steps इस patient में उठाएंगे. So for the management of this patient, the correct step would be that we will go in for anticoagulation. The correct answer for this one is option number A. एट्रियल फिब्रिलेशन जब भी पढ़ोगे ना तो उसमें स्टेप्स का बाईपास नहीं बताया हुआ है, क्योंकि एंटीकोगुलेशन करे बिना अगर हम केमिकल कार्डियोवर्जन करते हैं, यू नो ऑल द ऑप्शंस दैट आर प्रेजेंट, उसमें कार्डियोवर्जन सब में आ रहा है. I mean, as a universal statement, I can say, if you straight away do cardioversion in atrial fibrillation, you will treat atrial fibrillation. Good news. The bad news is that now the heart will contract with normal power. If it contracts with normal power, the chances of clot going into the brain will increase, because earlier the twitching was still keeping the clot in the atria. Now it will dislodge because proper contraction is occurring, which is the problematic fact here. So the correct answer for this particular question is option number A. Good job. Subsequently, I got A as an answer from almost most of the people. Great. Let's move on to the next one. Which of the following is a correct order of assessment for abdominal examination of client? This is a new question. This I'll not say is from the QBank. I put it deliberately because otherwise वो पुराने वाले सारे होंगे तो you'll be a little more comfortable. So I just put it just to put up that, you know, that check out whether you have done a per abdomen examination in a patient or not. So yes guys, what would be your correct answer in this case? Okay, so I'm getting inspection, palpation, percussion, auscultation. अब सोचो यार, किसी को पेरिटोनाइटिस है, आपने पैल्पेशन कर दिया उसका, उसके बाद वो ऑस्कल्टेशन करने देगा आपको? आप खुद सोचो, अगर कोई पेशेंट आया जिसको पेरिटोनाइटिस है या इंटेस्टाइनल ऑब्स्ट्रक्शन है, पेरिटोनाइटिस लेते हैं, चलो कॉमन है ना पेप्टिक अल्सर डिजीज में, आपने उसका रिबाउंड टेंडरनेस चेक किया, आपने प्रेस किया, छोड़ दिया, उसके बाद वो परकशन, मतलब सोच के देखो, कोई अगर पैल्पेशन के बाद में परकशन करने देगा कोई एब्डोमिनल क्लाइंट जो है? सर, फॉर एब्डोमिनल एग्जामिनेशन ऑफ अ क्लाइंट व्हाट इज रिकमेंडेड इज नॉट द स्टैंडर्ड थिंग. हम लंग्स की बात नहीं कर रहे, एब्डोमिनल एग्जामिनेशन की बात कर रहे हैं. विल बी डूइंग, पहले तो इंस्पेक्शन ही करेंगे, एंटीरियर एब्डोमिनल वॉल देखेंगे, उसके बाद फिर ऑस्कल्टेशन करेंगे, परकशन, लास्ट में पल्पेशन करेंगे. सो द पॉइंट इज विद रिस्पेक्ट टू अ पर्सन, I mean, if I will be doing a inspection followed palpation पहले कर दूंगा, तो patient will not let me touch him, he will not let me auscultate him. So with respect to per abdominal examination, though ये थोड़ा सा controversial है, but I'll not get into controversy at the moment. The point is, the logic is, for clinical examination, per abdominal examination, if we straight away palpate a patient, and God forbid if there is a rebound tenderness, then the remaining examination cannot be done. Yes, Ankush gives a right direction to this particular discussion that I'm doing at the moment. He said pain will be given in the last in the patient. That's perfectly right. I mean, that is the essence of this discussion, that every time you're doing a per abdominal examination, if you do straight away palpation and the person is sick, he'll not let you do auscultation. Answer to this one is option number D. Yep, Suresh, you are spot on for this one. Let's move on to the next question. This patient is a victim of a mugging episode. He was punched on the temple a couple of times and is presented with a bloody watery discharge from the ear, probably a CSF occurring in this patient. That's a CSF otorrhea. And this guy, he came out of ATM. Some other guys were standing outside and they knew that this guy is carrying dollars. So they punched him and they tried to take away his dollars. And unfortunately, I mean, this guy got injured. So let's look at, you guys can give me an answer for this one. I think this is a repeat one. The question is saying what will be, yes. Okay, fine. So I'm getting various answers in this particular case, and I expected, because this is a repeat question, the answer should not go wrong. I'm getting a B and I'm getting a A also, handkerchief test. So you guys have to be a little more careful. I mean, ये गलती नहीं कर सकते सर. साइट ऑफ CSF लीकेज, क्या हैंकरचीफ हैंकरचीफ से टेस्ट से हमें पता चल जाएगा व्हाट इज द साइट ऑफ CSF लीकेज. वुड a double ring sign on filter paper or beta 2 transferrin on immuno. IFE क्या होता है? Immunofixation electrophoresis ना. IFE would be immunofixation electrophoresis. The point is that साइट थोड़ी ना पता चलेगी हैंकरचीफ टेस्ट से या डबल रिंग साइन से या बीटा 2 ट्रांसफरिन से. ये साइट वर्ड नहीं होता, फिर आंसर सी था. If site was not given in the question, the answer would have been option number C. But because site is given, ये इसको silly mistake बोलते हैं. The correct answer for this question is option number delta. It is a CT cysternography which will help us know the exact site. अगर ये site नहीं होता question में, if the site word was not given, then the answer would have been given as option number C. तो कोई बात नहीं. I mean, some go correct, some go right. Doesn't matter. Again, the point is, since C came up in the chat again, I'm repeating once again. If the question simply said which of the following is best for determining that it is CSF, then it is okay. Beta 2 transferrin by immunofixation would be the answer. But because he has mentioned the word site here, that is why the answer to this question would be option number D. Okay, fine. I think now, yeah, specific test is what we have sorted out. Okay, no issues. Let's talk about another one. This question says which patient should be started on aspirin for secondary prevention of atherosclerotic cardiovascular disease. More of, more testing your knowledge of PSM with respect to secondary prevention and primary prevention fact. Yes, guys, waiting for your inputs here. We are having a 75-year-old chap. He's having hypertension. Then there's a 60-year-old chap with diabetes and atrial fibrillation. We have to start aspirin, remember. Then a guy with a hemorrhagic stroke and upper GI bleed. इसको तो करेंगे नहीं, ये तो मैं ही आपके लिए रूल आउट कर देता हूँ. A guy who's already had a hemorrhagic stroke and upper GI bleed, I'll not be very comfortable giving aspirin to somebody who's had a GI bleed. So C is not the correct one. Let's look at what you guys have commented before I give my final answer. Okay. B पढ़ते हैं. B एक बार वो A भी आया. 75-year-old man with hypertension. तो एस्पिरिन हाइपरटेंशन में हेल्प करेगा क्या? मतलब हाइपरटेंशन वाले को हम सेकेंडरी प्रिवेंशन के लिए एस्पिरिन देंगे या एंटी हाइपरटेंसिव ड्रग देंगे? If a person is having hypertension which is severe enough to be causing problem for him, would you give aspirin? Or would you be giving calcium channel blockers? Since the blood vessels have become relatively hard, the BP would anyway be on the higher side. But if he is having increased risk of cardiovascular mortality, I would be giving calcium channel blockers for this patient if the BP is like 180, 190s or even higher than that. 60-year-old man with diabetes and atrial fibrillation. So if somebody is having atrial fibrillation, I'll be more comfortable giving anticoagulation in this patient, not give aspirin to this patient. बट स्टिल इफ़ यू आर सेइंग बी, मैं फिर भी मान लेता हूँ कि चलो आपने एट्रियल फिब्रिलेशन सोच के बोला कि हम यार एस्पिरिन दे देंगे कहीं उसको स्ट्रोक ना हो जाए. लेकिन डी देखो ना, अगर किसी को TIA हुआ है तो मैं 2-3 बार ये तो एक्सप्लेन किया है, रूटीन ऐप में भी, एक्सप्लेनेशंस में भी प्रेजेंट है, QBank में भी प्रेजेंट है. डुअल एंटीप्लेटलेट थेरेपी फॉर एनी पेशेंट हैविंग अ ट्रांजिट इस्केमिक अटैक टू प्रिवेंट हिज डिटरिएशन इनटू चांसेस ऑफ डेवलपमेंट ऑफ स्ट्रोक, ताकि उसको स्ट्रोक डेवलप ना हो, टू प्रिवेंट स्ट्रोक फ्रॉम अकरिंग इन दिस पेशेंट्स. What you need to do is start them on dual antiplatelet therapy. So aspirin will be one of the major approaches that you'll be using in this patient. The correct answer for this question is option number delta. Let me just check out how many got this correct. Yep, initially the feed was a little wavered between A, B, and then ultimately D came in the picture. See, the bottom line is if somebody's had a TIA, you know that there could be further development of stroke in a patient. We have a special score available which is called as ABCD2 score, and on the basis of which we can calculate the percentage of chances of development of stroke. A is age, B is blood pressure, C is clinical feature, D is diabetes mellitus and duration. So ABCD2 score is used to determine the chances of development of stroke in a patient. That is one. And yep, sir already updated है, most of the stuff is already updated, तो आप उसको सुन सकते हैं. ABCD2 score is gonna prevent the chances of stroke from occurring in this patient. Multiple correct, B versus D. Okay, Shreyansh, I take your point there, considering atrial fibrillation. Yep. But anyway, primarily for atrial fibrillation will be more comfortable. और atrial fibrillation के लिए भी यही बोलूँगा कि first option will always be if it is rheumatic heart disease causing atrial fibrillation, RST with MS with atrial fibrillation, it is warfarin. If it is non-rheumatic, तभी उसको NOAC आंसर करना. Somebody had commented NOAC in the option, so novel oral anticoagulants are only to be answered for non-rheumatic etiology. If he himself says that patient is having rheumatic heart disease, there is a mitral stenosis which is causing a atrial fibrillation. If rheumatic word is given in a question, the usual Indian scenario, then answer would be given as warfarin only. And in case he says non-rheumatic, then it's gonna be answered as novel oral anticoagulants. Yep, so we are sorted for this one. Any use of NOAC here for patients? Yeah, absolutely. NOACs would also be used in the patient. Anuj, definitely true. If a person is having a transient ischemic attack, we'll first try to go into the causes, no? Only if he demonstrates, that is when atrial fibrillation is demonstrated, that NOACs would be used. So I think the query which one doctor raised was, is there any role of NOACs in point number D? I said, if atrial fibrillation is documented, the answer is yes. I will also try to find out what is the etiology behind development of atrial fibrillation. Is it rheumatic or non-rheumatic? Like in Western countries, it will be non-rheumatic. So standard answer is NOAC in Western countries or USMLE exam. In India, if they incorporate rheumatic, then answer is always going to be given as warfarin in the patient. We are sorted with D. Let's move on to the next one. That is 75-year-old chap. He's having chronic congestive heart failure. And he's having a pitting pedal edema. Standard things, I mean, heart failure patient is bound to have pitting edema, and echocardiography shows a ejection fraction of 35%. It's not a standard 65%. Is already on ACE inhibitors, furosemide, potassium chloride, because furosemide will contribute to hypokalemia. So the doctor has anticipated the muscle cramps which will occur in this chap and has decided to give potassium chloride to this patient in advance only. And this guy is also on rosuvastatin and aspirin. Considering that he's on statins also and on aspirin also, I presume this guy would be having ischemic cardiomyopathy. He might be having some coronary artery disease. He did not get stenting done or coronary artery bypass grafting done, because of which he has suffered from ischemic cardiomyopathy, because of which, I mean, the reason why statin is there is there has to be some coronary artery disease in this patient, which has contributed to damage to the heart, and thereby he's gone into congestive heart failure. Yes, guys, I'm waiting for answer. What other medication should be given to this particular chap? Any patient having congestive heart failure, एक आंसर आया जी डी, डिजॉक्सिन. तो डिजॉक्सिन क्या देते हैं क्या? कार्डियोमायोपैथी के मरीज में डिजॉक्सिन देंगे, वो तो हार्ट के ऑक्सीजन कंजम्पशन बढ़ा देगी, उससे तो वर्सनिंग हो जाएगा. सर, वी डू नॉट यूज डिजॉक्सिन इन structural damage to the heart to the level that the person will have an upgrade of oxygen consumption. If you have listened to the discussion for chronic congestive heart failure, we mainly use A plus B. That is all the question is asking कि भाई करोगे क्या? तो A के साथ A तो ऐड करेंगे नहीं, उसको लिस्नोप्रिल चल रहा है तो लुसाल्टन तो ऐड नहीं कर देंगे ना. देयर इज नो पॉइंट ऑफ एडिंग A plus A. A plus A तो देते नहीं है क्योंकि हाइपरकलीमिया का रिस्क रहता है. There is no advantage of giving A plus A. There is risk of hyperkalemia, so we will not combine A with A. So what we will do in any patient of congestive heart failure is give A plus B, that is beta blocker, which should be given because the prescription of the patient is at the moment incomplete. He's still having features. So if we are gonna use beta blocker and conserve oxygen, it would be beneficial for this patient. The main reason why beta blockers are mortality reducing with congestive heart failure, ये तो even FMG में पूछा हुआ है ना यार कि beta blocker, which drug is gonna be reducing mortality in chronic congestive heart failure? The answer is beta blocker. तो pity, I think that was a pretty straightforward one. The correct answer for this one is C. Isosorbate dinitrate कब यूज करेंगे? सर वो तो तब यूज करेंगे ना जब चेस्ट पेन होगा. रीजन वाई आई एम रोलिंग आउट ऑप्शन नंबर सी इज कि अगर चेस्ट पेन होगा तो मैं आइसोसॉर्बेट डाइनाइट्रेट यूज करूंगा. डिजॉक्सिन का प्रॉब्लम है कि इट कैन अपग्रेड, बेसिकली वो फोर्स ऑफ कंट्रैक्शन को बढ़ाती है. डिजॉक्सिन यू नो इज अ पॉजिटिव आइनोट्रोपिक एक्शन. इट अपग्रेड्स द फोर्स ऑफ कंट्रैक्शन, एंड if I'm gonna upgrade the force of contraction, then the problem is gonna be that it will increase oxygen consumption of the heart, and that will be detrimental to the health of this patient. So we have ruled out all the options here. I'll say that once again just to complete it, next 15 seconds. Option number A is ruled out because we do not combine A with A. Option number C is ruled out because that's useful for management of chest pain. That does not treat features of congestive heart failure. And D, if you're gonna upgrade the force of contraction, आपको फ्यूल चाहिए ना सर, ताकत के लिए फ्यूल चाहिए, और फ्यूल अगर आप कंजम्पशन बढ़ा दोगे तो that will be counterproductive in the patient. The major mortality reducing drug in congestive heart failure chronic variety is beta blocker. So a vasodilator should not be used. Yes, that is another reason why we should not be using a vasodilator, because anyway in this patient the blood pressure will also be on the lower side. What will we do to improve? Ankush said, what will we do to improve, doc? I could not pick up the whole comment. Okay, do improvement of this case. Yeah, beta blockers would cause improvement in this patient, and maybe the dose of diuretics needs to be a little adjusted. We need to check the compliance of furosemide and maybe adjust the dose of furosemide, and that should do the problem for resolving the pitting edema in this patient. Most of the stuff I'm talking, doctor, is in English only. What is normal ejection fraction? 65%, Tarun. Normal ejection fraction is 65%. This guy is HF ref. Heart failure with reduced ejection fraction. Every time there is HF ref in a patient, ref means reduced ejection fraction, the EF would be less than 40. So I suggest you to read up the topic of congestive heart failure with respect to HF PEF and HF ref. HF PEF is heart failure with preserved ejection fraction. HF ref would be heart failure with reduced ejection fraction, and ejection fraction is gonna be the output of the heart. No, that's gonna be stroke volume divided by end diastolic volume. I mean, every time our heart will relax, it will receive 130 ml blood. It will kick out 80 ml blood. So if you divide the 280 by 130, it is 65%. In this case, there's a structural damage in the heart, probably due to ischemic cardiomyopathy. How do I know it's cardiomyopathy, ischemic variety? Because the chap is on statins and aspirin. So to improve the ejection, no sir, we cannot improve ejection fraction of the heart. If it is damaged, it is damaged. We can't be God. Only way we can increase it by using left ventricular assist device or doing a cardiac transplantation. So if we want to improve cardiac ejection fraction, nothing would do, sir. Heart muscles are damaged. Yeah, I'll explain it a different way. You know, a lot of guys come up with this query, sir, why can't you increase the ejection fraction? Sir, the muscle is dead. What is the point of feeding the dead? Whatever is the alive tissue, you need to feed it, no? But what is the point of feeding the dead? The dead tissue is damaged. So even if you give a drug that will, suppose, you say, sir, can't you give a dilator that will increase the blood supply to the damaged part of the heart? I said, no point of feeding the dead tissue. Well, I mean, even if you give nutrition to it, it's over. There's a scar formation there. So can we give low dose dopamine, sir? If it was an emergency with respect to that this guy went into cardiogenic shock, then we can give dobutamine to this patient on a transitory basis to prevent renal failure. The logic behind giving dobutamine is not that it's gonna improve. We can't give dobutamine infinitely to the patient. It is simply the fact that dobutamine will ensure the perfusion of the kidney so that we can at least prevent acute kidney injury in a patient. So inotropes are given in acute congestive heart failure if person is going into cardiogenic shock, because that will happen due to pump failure in MI. So you need to give inotropic support to ensure perfusion of the kidney and prevent a multi-organ dysfunction developing in this patient. It's not going to be therapeutic to the level that the ejection fraction will normalize. As I said, I mean, there's no point of feeding the dead tissue को आप कितना भी खिला लो, कोई फायदा नहीं है ना. Blood supply, if we give to this area, that is why we advise coronary artery bypass grafting. No, that is why इस patient को, इस भाई को मैं समझाया था, भाई तू कैबेज करा ले. I had told this guy, please get a revascularization done. I'm speaking both in Hindi and English, the same thing in English also. So the point is, I had told this chap for a revascularization procedure. Initially, he did not listen. That is why this is happening. Or maybe we were advising this guy to get stents deployed, PCI with stenting. He did not undergo any one of these. That is why the features would be occurring in these patients. Yup, Dr. Hussain, that happens because that is why my recommendation would be that on a loop on YouTube, you should listen to sessions. When you try to do it by yourself, because there are so many distractions, questions can go wrong. But here, when you're focusing with me, you're listening to me, you're analyzing the data, and you are able to narrow down to the options because I'm ruling them out for you. So the main advantage of a lot of chaps, what they do is simply, and those who have cleared the exam, I'm saying, they have simply said, sir, all we do is put your videos on loop, the discussion part, not the main videos at the moment before the exam. And they just keep on listening to the explanation part of the MCQs. That would, no, now, doc, it would not, Ravi, it would not help. Okay. EECP, exactly, learning soul, that works because it improves the diastolic blood flow. No? So EECP has been shown for practical knowledge. Yes, it works. It works. Hi Anup, how are you? Moving on to the next one, we have this elderly gentleman who's having a neck mass he is noticing a progressively enlarging neck mass over the previous 2 weeks with weight loss. It's a she, and she has hoarseness of voice and she feels as if the food is stuck in the food pipe. So there is a thyroid mass, there is a cervical lymphadenopathy, it's pressing on the trachea, that is explaining the hoarseness of voice. It is probably pressing even on the on the esophagus of the patient. So the patient is getting dysphagia and getting a sensation of food stuck in the windpipe. I mean, it's a local thyroid mass, and because there's a lymphadenopathy, so the diagnosis of this patient, okay, is written only himself, thyroid cancer. You know, I could pick up thyroid cancer from the first 3 lines, but he has himself written thyroid cancer in this patient, and that too of the anaplastic variety. Is linking this with pathology. You are all aware of the various types of thyroid cancers. The commonest one is papillary cancer of thyroid, and he's asking regarding what is the gene that would be involved in this case. So if we look at option number A, CDKN1B gene, this looks familiar. We read about this in multiple endocrine neoplasia type 4. So I'm ruling out option number A because this gene, and genes are something which is everyday task. Try to make a list by yourself where every day you read a gene or a chromosome, note it in a separate copy and try to remember it, or try to go through the same paper in your own handwriting again and again so that it can just be internalized. Option number A is for MEN4. Ret proto-oncogene is for multiple endocrine neoplasia type 2. In this case, is talking about anaplastic cancer. So that would be unlikely because in MEN2, we'll be having medullary cancer of thyroid. And he has himself mentioned regarding anaplastic variety on FNAC. We are left between C versus D, calcitonin receptor mutation. Well, calcitonin anyway comes with respect to medullary carcinoma thyroid. So we are going to be talking about a mutation which is responsible not only for anaplastic cancer, but also for the commonest cancer of thyroid, that is papillary cancer. I mean, every time you read about the genetics component with respect to, every time you read with respect to genes or mutations or chromosomes with respect to various, thyroid cancers, BRAF would be right on the top. BRAF cancer, BRAF V6E mutation would be seen with respect to papillary cancer as well as anaplastic thyroid cancer. So we are sorted. Yep, absolutely, Dr. Ansari. It is seen with papillary thyroid cancer, and it is also seen with anaplastic cancer of the thyroid. Anaplastic is locally aggressive, so it squeezes the trachea, it squeezes the esophagus of the patient, which is why in these patients, mainly most of the time, we'll be doing a isthmectomy in the patient initially, so that at least there can be relief of local symptoms present. The correct answer to the current question on the slide is option number D. BRAF mutation is for papillary thyroid cancer as well as for anaplastic cancer. Okay. Moving to the next one, we are having a 30-year-old patient who's presenting with the shortness of breath and ankle edema, and she has received chest irradiation for Hodgkin's lymphoma in the childhood. Which of the following findings is expected to be present with respect to this patient? Considering that there is shortness of breath and ankle edema, that means heart involvement is there. And because there is chest irradiation occurring in this patient for Hodgkin's lymphoma, there can be two possibilities. Either the patient is having calcification outside the heart, that is constrictive pericarditis, or there could be fibrosis in the myocardium also. This fibrosis in the myocardium can result in restrictive cardiomyopathy developing in this case. So considering the fact that any patient is having, these are the two possibilities which are to be considered. I'm getting C, abnormal myocardial texture and restrictive diastolic dysfunction in this patient. Okay. So we need to now take into consideration which of the two would be more common. Would calcification be more common, or will fibrosis be more common with respect to irradiation? So guys, the point is that radiation to the chest is a risk factor for development of both. First it is calcification written and then fibrosis written. So I'll put it like this, that calcification is the one which is to be thought first in this question, and then subsequently the fibrosis component, because the outermost layer of the heart will be exposed the first. आउटरमोस्ट लेयर ऑफ द हार्ट इज पेरिकार्डियम. तो जब रेडिएशन मिलेगा चेस्ट को तो पहले पेरिकार्डियल डैमेज होगा, फिर मायोकार्डियम में डैमेज होगा. तो बिकॉज ऑफ द फैक्ट दैट द रेडिएशन विल फर्स्ट अफेक्ट द पेरिकार्डियम एंड देन द मायोकार्डियम, बोथ कैन बी अफेक्टेड, बट calcification is more likely because the radiation comes from outside, so pericardial damage will occur. So you have to give answer with respect to constrictive pericarditis in this patient. The answer to this question is not option number C. Sir, it's not a dilated left ventricle. It's not a dilated cardiomyopathy. If you have to answer, you should answer restrictive cardiomyopathy. तो D तो आंसर बनता ही नहीं है. Why it is not D is because D means that there would be dilated cardiomyopathy, there can be restrictive cardiomyopathy. The logic I am saying is that in the patient there is a calcification occurring outside the heart because pericardium is in the outside of the heart. So you have to answer it with respect to A versus B in this particular case. So let's look at the answers now. I think I'll get a change now in the perspectives. There is a impediment of both early as well as late diastolic filling this finding where both the early and the late diastolic filling is compromised. This is a feature with cardiac tamponade, because in cardiac tamponade no filling in the blood will occur, neither rapid ventricular filling. Both the early and the late part would be affected. You see constrictive pericarditis tends to have, अब मैं diagram से दिखाता हूँ, I think आपको better समझ में आएगा. You see in patients who are having constrictive pericarditis, what's going to happen is that there is going to be calcification outside the heart, and this calcification will say atria will get dilated, and because the atria getting dilated, those atria will contract with more force, so that you just think about this once again. Imagine there is calcification around the ventricles. Because of the calcification which is occurring around the ventricles of the patient, the atria will dilate, and therefore this atria and on the long term basis will also hypertrophy. So the atria will contract with more force as compared to normal, because there is a calcification around the ventricle. This patient is having a stiff ventricle. तो क्योंकि atria ज़्यादा force से contract करेगा, तो there would be a rapid ventricular filling occurring in this patient. But later part of filling will be hampered because there is a calcification occurring in this patient. The correct answer for this one is option number A. थोड़ा difficult था. I think echocardiographic findings, I mean, at an undergraduate level I have the right to put few difficult ones also. So I'm just trying to put a mixed bag of questions. I agree that out of all the questions that I've discussed for today, I would rate it as the most difficult one. But yeah, those of you who are sitting for INI-CET would realize the importance of this question per se, because in the recent times I've seen a shift where they've tried talking about echocardiographic findings. I'll repeat the logic once again. Cardiac tamponade में filling होती ही नहीं है. There's hardly any filling occurring, so there would be impediment of both early as well as late diastolic filling. In constrictive pericarditis, because there's a calcification around the heart, there's a stiff ventricle, so atria ज़्यादा जोर से contract करेगा. That will explain the rapid early diastolic filling. This will also explain the pericardial shudder that occurs in these patients, and impaired late because calcification तो बाहर है. So blood will be first able to rush in, and then there is an impediment that is occurring. So it would be a development of rapid diastolic filling and an impaired late diastolic filling in a patient. Cardiac tamponade, there is no filling occurring. Echocardiographic finding number 1 is a feature of constrictive pericarditis. Finding number 2 is with respect to cardiac tamponade. We are sorted for this question. Answer is option number A. And मेरा पर्सनल व्यू तो सर कुछ मैटर नहीं करता. आई एम टू स्मॉल इन दिस एंटायर hierarchy order to say that what is when my comments would really not matter. But yeah, I think the current system was going well, and any changes. Okay. Doc, you have to study a little more harder than my teaching would make sense to you. Otherwise, at a baseline level, the understanding part would be a little more difficult for you to comprehend. So, I mean, apologies. You need to fix the baseline issues. Okay, let's move on to the next one. We have a 70-year-old man who's complaining of dizziness for the past 2 weeks. You need to upgrade, right? 70-year-old man is complaining with dizziness for the past 2 weeks, which is getting worse, and the vertigo. This is a combination with ENT. The chap is having breathing difficulty. The chap is having dizziness for the past 2 weeks. The vertigo does not change with position, because every time we read about vertigo, one of the common diseases that we're going to read is benign positional vertigo. In this particular case, it is written the vertigo component does not change with position. So considering that, it is very unlikely that BPVV would be considered in this question. Then there is no history of any ear pain, discharge, ringing in the ear, standard ENT data that he has given. There's a vertical nystagmus that does not disappear with repeat testing, and the hearing is normal in this chap. That is ruling out, okay, I'm getting Meniere's disease. Meniere's disease में तो deafness होता ना. Meniere's disease is deafness and vertigo and tinnitus in a patient. So there is no impairment of hearing in this patient. There is no deafness in this patient, so the answer cannot be Meniere's disease. ना तो D तो बनता नहीं है सर. ये तो मतलब I'll say like this is more of a ENT/medicine based question. We are reeling out option number D because Meniere's disease should be having deafness. And benign paroxysmal positional vertigo में जब वो head का position turn करेगा, that is when vertigo will come. So 2 points तो वैसे ही मैंने rule out कर दिए. Now you're left between 2 possibilities, A versus C. And the concept behind this question is to differentiate between peripheral versus central causes of vertigo. पेरिफेरल कॉज होता है जैसे कि लैब्रिंथाइटिस, और सेंट्रल कॉज होता है जैसे कि सेरिबेलर ट्यूमर, क्योंकि सेरिबेलर में किसी को डैमेज होगा तो सेरिबेलम के डैमेज की वजह से उसको वर्टाइगो भी होगा, डिजीनेस भी प्रेजेंट होगा, देयर वुड बी अ सेंस ऑफ इम्बैलेंस प्रेजेंट. The key word in this question that you need to pick up is the statement that the vertigo of the patient does not disappear with repeat testing. क्योंकि जो पेरिफेरल वर्टाइगो होता है उसका जब भी आप इलेक्ट्रोडायग्नोस्टिक टेस्ट करते हो तो द वर्टाइगो कैन बी सप्रेस्ड और द nystagmus in the patient can be suppressed. The nystagmus component can be suppressed. There's a table which is given in the textbook for describing the manifestations between central and peripheral, but even if you don't get into it, the main point for differentiating between the two is that central versus peripheral cause mein nystagmus which can be suppressed is peripheral cause, and nystagmus that cannot be suppressed is central cause. Central matlab cerebellar cause in a patient. The correct answer for this question is option number C, that is a cerebellar disease in a patient. So I think most guys did very well to pick up the option number C in this case. You had to pick up this line, a very small line which is given in the question, that the finding does not disappear. The nystagmus component does not tend to disappear with respect to labyrinthitis. There would be no fever also present. That's another hint that is present. But anyway, I mean, I'm not trying to solve it on the basis of clinical history. I'm trying to solve it on the basis of the testing which is present. And deafness component can be present in labyrinthitis. Absolutely. Sir, देखो point ये है कि the main way to differentiate between the two for this particular question is not the clinical finding, it is the electrodiagnostic finding that is present. The electrodiagnostic findings are always going to be superior as compared to the clinical findings. So cerebellar tumor is the one which is to be considered. I mean, उसमें हमेशा आपको focus जो करना है, that is on the electrodiagnostic test which are given in the question. It's possible to complete. Doc, एक और comment आएगा तो then I'll be able to see your comment. Anyway, we're sorted for this one, option number C. Let's move on to the next one. A 58-year-old man, Utkarsh, your comment I cannot see at the moment, it's hidden somewhere, so probably somebody else will comment, so it will move out, और आप ही कुछ कर. Okay, within 1.5 year. सर लोग 4 महीने में खत्म कर रहे हैं, तो 1.5 year तो बहुत ज़्यादा है. Okay, moving on. 58-year-old man presents with shortness of breath with exertion for last 2 years. And the chest X-ray of this patient is showing enlargement of central pulmonary arteries, attenuation of peripheral pulmonary vessels, oligemic lung fields. तो उसने खुद ही बता दिया कि pulmonary artery hypertension का क्वेश्चन है. Any patient with pulmonary artery hypertension, less blood supply to lung will explain the shortness of breath which is present in this chap. And he's saying what drug would be used for management of this patient. You have to just use a pharmacology in this case. Ranolazine is used in chronic stable angina. Rivaroxaban is a novel oral anticoagulant. This novel oral anticoagulant is used in transient ischemic attacks, or it is used in atrial fibrillation to prevent clots from developing further. Roflumilast is a phosphodiesterase 4 inhibitor. This is used in management of COPD. So you can rule out the options here and come to the correct answer for this question, that the drug that will be used for management of this patient would be a soluble guanylyl cyclase stimulator. This is an oral molecule. It will increase because cyclic GMP levels will cause a vasodilation and it will treat the pulmonary artery hypertension of a patient. The correct answer for this is option number beta. You just had to use a pharmacology in this case, guys, that for treatment of pulmonary artery hypertension, this question, because this is relatively a newer drug, the mechanism of action of the soluble guanylyl cyclase stimulator would be that it will cause a vasodilation. And as a result of it, I mean, the advantage is going to be that the pulmonary artery pressure will become relatively lesser and the pulmonary circulation will improve. You have to solve this question by exclusion capability. Option A is for chronic stable angina. Option C is for TIA and AFib. Option D is for management of COPD. So I think we are sorted for this one. Answer is option number beta. For the upcoming July exam, no sir, you should exit the session. That would be a little more difficult for you to handle it at the moment. Okay, moving to the next one. In which of the following conditions would a Ryle's tube inserted be felt per abdomen palpation? I mean, normally we are not able to feel a Ryle's tube, right? When you put it anytime you put a Ryle's tube, you cannot feel it per abdominally. But in this particular question is saying that the doctor is able to feel the Ryle's tube. So he's saying which of the following conditions would be responsible for this. I think everybody is understanding that the problem would be lying in the stomach of the patient only. I mean, if, okay, I'm getting a in this case, stomach volvulus. So people saying stomach volvulus, सोच के मुझे बताओ, will you be able to feel the Ryle's tube, or Ryle's tube will not go inside? Stomach volvulus presents with, are you able to feel a Ryle's tube, or is there a failure to pass NG tube? Yes guys, waiting for your answer. अगर stomach volvulus होगा, if the stomach will get folded on its own axis, if the stomach gets folded on its own axis, then there would be a failure to pass nasogastric tube. The question is not asking regarding failure to pass nasogastric tube. He's saying the Ryle's tube is being felt parabdominally in this patient. Stomach cancer answer aa raha hai. Okay sir, let's say people are saying stomach cancer mein Ryle's tube fail ho jayegi. So what you need to pick up here is, guys, I'll just show you an image. I think that will make it relatively easier for you to pick up. कि यहाँ पे stomach is like, this is the stomach of the patient, and the stomach has been totally compressed, and the posterior wall of the stomach is being pushed anteriorly because there is a pseudocyst of the pancreas. This patient suffered from pancreatitis, and the pseudocyst of the pancreas is responsible for pushing the wall of the stomach anteriorly, the posterior wall anteriorly. And if the stomach wall is pushed like this anteriorly, then the doctor might be, or you might be able to feel the nasogastric tube, which could be lying inside this area. I mean, there's an NG tube present here, so you'll be able to feel the NG tube because the pancreatic pseudocyst has pushed the posterior wall of the stomach anteriorly. The correct answer for this one is mesenteric cyst. मैन mesenteric cyst की फाइंडिंग तो टिलुक्स ट्राइड होता है यार. आई मीन mesenteric cyst में NG ट्यूब कैसे फील हो जाएगा? The correct answer for the current question on the slide is option number beta. I expected answers here, maybe because of थोड़ा सा domain मैंने change कर दिया and I put up a question that had a surgical overlap. Suddenly, I mean, I started having answers which were a little weird. So mesenteric cyst will be having like it's perpendicular to the mesentery, no? So you have a resonance. There will be dullness on percussion on a mesenteric cyst, और उसके आसपास में resonant band present होता है, and the swelling is mobile in only one direction. So we read about Tillot's triad with respect to mesenteric cyst. पढ़ना इसको surgery में in Tillot's in mesenteric cyst, you will not be putting a Ryle's tube in a patient. But if there's a pseudopancreatic cyst and he's vomiting, you have decided to put an NG tube, and the NG tube is being felt parabdominally. That's the only scenario where you can feel the NG tube anteriorly, would be a pseudopancreatic cyst of pancreas. The logic is what I showed you with respect to a CT image, which is that the posterior wall of the stomach has been pushed anteriorly. The correct answer for this one is option number beta. Is it good to study pathophysiology for university exams in medicine? Sir, you have to study pathology, only then the medicine point will make sense, no? So in short, obviously it has to be read. I don't mean you need to read 2-3 pages from Harrison, but yep, you need to go through at least the data that is told to you in the video lectures, and you need to go through the data that is given in Davidson, for example. Okay guys, we do the last question for today, and I expect the correct answers here. The question says the black crescent is the stomach. Exactly, Aditya, that is the stomach of the patient that has been pushed anteriorly, and then is the pseudopancreatic cyst of the pancreas. Okay guys, coming to the last question for today. What is the best management for portal hypertensive gastropathy? And well, I'm getting A as a feed at the moment. Let me wait another 10 seconds, waiting, and then I'm getting D. Spironolactone with furosemide. Well, spironolactone with furosemide will be for ascites, so that would anyway not be the answer. I'm getting a endoscopic varicose ligation. So endoscopic varicose ligation is done for patients who are having esophageal varices. If a person is having bleeding esophageal varices, or if a person is having non-bleeding esophageal varices, we go for endoscopic varicose ligation. Is this question talking about esophagus, guys? Please read the question carefully. Is the question asking you with respect to, is the question saying that the patient is having a varices? Absolutely not, man. He's asking about a gastropathy. Minnesota tube insertion or endoscopic varicose ligation, all these steps are gonna be done for esophageal varices in a patient. The question is asking you with respect to portal hypertensive gastropathy, what would you do to reduce the pressure in the portal circulation? You will be giving beta blockers in a patient. The correct answer for this question is option number C, that is ladelol. See, option number A and B are for active intervention with esophageal varices and not with respect to portal hypertensive gastropathy. It will continue to bleed as I've explained in routine videos, and we need to use beta blockers for these patients. If यहाँ पे gastropathy नहीं होता, if this question was talking about esophageal involvement, then the answer would have been A. Yeah, tips can be done, Dr. Ansari, subsequently in the patient. But initial management in these patients is nadolol or propranolol. I mean, either of the two drugs can be used, and that would go a long way to manage these patients effectively. The correct answer for this question is option number C. As I've explained, guys, I still got a B as a comment, so I'll just comment on this once again. A and B are for active intervention with esophageal involvement. The question is not on esophageal involvement, it is on stomach involvement. So, well, these are the details for today's session. So I'll be back again the same time tomorrow. We're doing multiple sessions for orientation for next over the next couple of days. In fact, we are doing 2 sessions in a day. In the morning session, it was surgery. In the evening, it's going to be medicine. Even if you are an FMG student who's going to be sitting for July exam, this was going to be beneficial for you in a sense that the questions might sound a little difficult, but then even in FMG exam, difficult questions are coming. So I think that we should not try to make any distinction for that between the various exams, because after all, it's gonna be a universal exam for everybody. And if you are into final year, if you are into intern, and if you are having time at your availability with respect to studying, then I think listening to these discussions would help you hone your reflexes and would help you narrow down to the correct option. There are some that went wrong today, some that went correct today. So I mean, we don't need to be overconfident for once that we got correct. We don't need to be underconfident for once that go last. We have to control our emotions. You have to control your emotions right till the very last movement of the last MCQ is solved by you in the actual exam. Before you click on the submit session, you need to control your emotions on a daily basis so that you can do this performance regularly. It's a simple fact. Whether you have slept or not, आप कुछ भी excuse बनाओ, आप सोए हो नहीं सोए हो, खाना खाया नहीं खाया है, भूखे हो प्यासे हो कैसे भी हो, पर क्वेश्चंस आपने प्रैक्टिस करने ही करने हैं. जितनी ज़्यादा मेहनत कर लोगे अगर अभी के लिए जितना ज़्यादा हार्ड वर्क कर लोगे, उतना थिंग्स विल बी relatively better. Sir, it's miscellaneous topics that we'll be discussing. That would be surgery and medicine sessions would be done. So thank you so much, guys. God bless you. In case you have any queries, you can message me at marwahmedicine@gmail. In Instagram, if you're not in my friend list, then the message will go in spam and I'll not be able to answer you. Okay, so doc, at the moment, let's not talk about PCAM, etc. God bless you. Take care. Bye-bye.